everybody. I am Dr. Katie Unverferth. I am the director of the UCLA Women's Life Center. I'm the medical director of the maternal mental health program at UCLA, which pretty much comprises a perinatal intensive outpatient program, which is really great and special. We'll talk about it. I'm an assistant clinical professor, and in my free time, I also have a private practice in Santa Monica. Today, we're going to talk about postpartum depression. But what I'm going to try to do is I'm going to try to make it more interesting. I'm sure everybody in this room is familiar with postpartum depression, right? So I'm not going to go over the basics. What I'm going to try to do is talk about the nuances you might not be aware of, especially talking about etiology. And also what we're going to do too is we're going to talk about the newer treatments for postpartum depression, like the neurosteroids. So hopefully you will all feel comfortable prescribing them after this. Do I have a clicker? It's over here. Oh, on the table. Thanks. Great. All right, I am a consultant for Sage Biogen. That's my only disclosure. So objective, so kind of what we just talked about, right? So we'll talk about the epidemiology, we'll talk about the etiology. We're going to specifically focus on kind of GABA glutamate and hormonal dysregulation. We'll talk about the broader impact because I think part of the reason it's so important to treat postpartum depression is that it doesn't just affect the person who's having the disease, it affects the infant, it affects the partner, it affects the family unit, right? So it's really important to intervene. And we'll talk about treatment approaches like the neurosteroids, SSRIs, and some new interesting developments like psychedelics, ketamine, TMS, okay? Great. So definitions, I'm sure you know this, but antenatal means during pregnancy. Prenatal is a synonym to antenatal. Perinatal is before and after birth, but when we talk about perinatal depression, what that means is depression in pregnancy or in the postpartum. Postpartum, after birth, postnatal, synonym to postpartum. To start this talk, I think it's always important to really bring up the gender and sex disparities in research, right? So what we know is that there are sex and gender differences in disease prevalence and course. Women tend to have more adverse effects to medication and may benefit from different dosages, right? We know that it's just different, right? Male-only studies outnumber female-only in clinical research by 7-to-1. Women weren't incorporated into clinical trials until 1993, so we really need more research on both gender-diverse individuals and women. In this field, I think it's really important to be specific with your terminology, right? I will use the term woman today because most of the studies that I'm going to talk about were done on cisgender women, so people who are born female identify as women. But what we try to do is try to kind of use gender-inclusive terms, so use the language of womanhood alongside gender-neutral terms, okay? So I'll try to do that in my talk today. Let's get into the background. Just some facts that I think are important before we really dive into more detail. Okay, so hormonal influence. So over the lifespan, women are twice as likely to experience depression as men. That's really interesting. This difference starts at puberty, so that's when hormones come into play. It increases in the perinatal period because we know people are at much higher risk of having psychiatric disorders during that time, and then disappears after women go through menopause, okay? So there's this idea that while a woman is having cycles, while hormones are in play, there's an increased risk of depression. This is important because we believe that there is a hormonal subtype of depression. So there are depressions that are triggered by changes in levels of hormones. In general, what we think is that it's not absolute levels of hormones that are different, but while hormones are shifting, so while they're changing, for some people that triggers an abnormal mental health response, okay? Because not everybody gets postpartum depression, but everybody has that big hormonal change, okay? So the conditions associated, premenstrual syndrome, premenstrual dysphoric disorder, right? Depression, that's depression in the luteal phase. Hormonal contraceptive associated depression, which is interesting, right? So we know that some people have depression when they take hormonal contraceptive, but not everybody. And some people even do better from a mood perspective. But sort of the same patients who have postpartum depression, premenstrual syndrome, PMDD, probably also have hormonal contraceptive associated depression, depression in pregnancy, postpartum depression, Depression after weaning from breastfeeding is an interesting one. So sometimes we'll see that people have done well during pregnancy, they've done well in the postpartum, but when they wean from breastfeeding, that hormonal shift will trigger depression for some people. And it seems like generally, even if it doesn't trigger depression, it's definitely associated with anxiety. We see a lot of anxiety during that transition. We have also seen a mixed state and like a hypomanic episode from that transition, which is interesting because we know that oxytocin sort of regulates dopamine, and so there's a mechanistic reason why maybe that happens for some people. And then perimenopausal depression and anxiety as well from these hormonal shifts, okay? What I'm trying to do here is I want to talk about why this is important for you as psychiatrists. So the maternal mortality rate in the US greatly exceeds that of other developed countries, right? What we can see is that like Canada, Australia, Sweden, New Zealand, all of these other countries have lower rates than US Hispanic women, US white women, and US Black women. And what we know is that US Black women are really bearing the brunt of this burden. Their rate is 2.5 times higher than white women in the US. Why this is important is that suicide is one of the leading causes of maternal mortality, right? It's really devastating. It accounts for about 20% of postpartum deaths. And as psychiatrists, this is where we can intervene and where I want you to be aware of and know to intervene, right? Postpartum depression is the biggest risk factor for postpartum suicide, okay? Let's get into epidemiology of postpartum depression. So internationally, the prevalence of postpartum depression is estimated to be about 17%. In the US, it's closer to 12%. People will say between 10 and 15%. People who have symptoms of postpartum depression, that rate is a lot higher. So a lot of people will have symptoms. Europe had the lowest prevalence at 8%. That is thought to be because of paid family leave, guaranteed health care, just more support for the postpartum person. Rates generally tend to be higher in countries with lower socioeconomic status. What's interesting, though, is that these rates go through the roof for someone with a history of prior affective illness. So your patients, like any patient that you're seeing in a psychiatry clinic, is at much higher risk of postpartum depression, right? So especially those who have depression or anxiety. So for those with a history of affective illness, rates are as high as 40% for postpartum depression and 75% for the entire perinatal period. So again, it is not a time of stability. If you're treating someone during this time, you really need to monitor them closely and treat appropriately. Racial disparities, we know that immigrant and minority women have higher rates of postpartum depression than other groups. In the US, Black women are noted to have symptoms at twice the rate of white women. So important to be aware. A recent study found that 20% of Black women and birthing parents screened positive on the Edinburgh Postnatal Depression Scale, which we'll go into in more detail, versus 11% of white participants, okay? Let's talk about risk factors. So depression in pregnancy is one of the biggest risk factors for postpartum depression. What I will tell my patients is that stability predicts stability. So if someone, and kind of the inverse is true too. So if someone is depressed before pregnancy, they're likely to be depressed during pregnancy, and they're likely to be depressed in the postpartum, okay? So a lot of times I'll see people who, or not a lot of times, but sometimes I'll see people who come to my clinic and they want to get pregnant, but they're having a really tough time. They're having clinically significant depressive and anxiety symptoms. They're on a medication regimen, but it's not working that well for them. What we'll talk about then is that I often want to give them space. I want to give them a little bit more time before they get pregnant, because ideally we'll have someone feeling euthymic before they go through pregnancy. I always tell them it doesn't get easier during pregnancy or in the postpartum. Other risk factors, basically any type of hormonally mediated mood disorder puts you at a higher risk for postpartum depression. So all of the ones we already talked about. Fetal or newborn loss, newborn in the NICU, low social support, preterm birth, traumatic birth experience. Other ones that I think are interesting is season of birth actually increases the risk for postpartum depression. So if you give birth in winter, when the days are shorter, you have an increased risk of postpartum depression, which kind of makes sense. Other ones, difficult infant temperament increases the risk for postpartum depression, perinatal sleep disturbance, intimate partner violence. These are just other ones to be aware of. But the biggest one is a history of depression. As an aside, I just think this is interesting. A history of hormonal contraceptive-associated depression is an independent risk factor for postpartum depression. So it's helpful to screen. People will know. This is an aside, but an interesting aside, is that the type of contraception used in the postpartum might increase the risk for postpartum depression. So this is something for us as psychiatrists to be aware of when we're treating someone in the postpartum. Because estrogen interferes with milk production, it's often recommended that women take progesterone-only hormonal contraceptives when they're breastfeeding. But the problem is that progesterone-only depot contraceptives are associated with an increased risk of postpartum depression, and it's thought that the mini pill is also associated with an increased risk of postpartum depression. So you could use the progesterone-only IUDs, but the higher the dose of progesterone in the IUD, the higher the risk of depression as well. So perhaps if you're going to use a progesterone IUD, you want to use the one with the lowest dose of progesterone, which would be Kyleena. The one I might recommend that's probably most compatible with someone with a history of mood disorders who's breastfeeding would be the drospirenone-only contraceptive. Drospirenone is a newer progesterone that doesn't seem to have the same mood deleterious effects. It's the same progesterone that's used in Yaz and Yasmin, if you're familiar with those. Yaz is the one that's FDA indicated for PMDD, just to kind of like link it all together. So this is the progesterone-only option that seems to not be associated with mood worsening. A little nitty-gritty, but very interesting to me. Okay, let's move on. Symptoms and diagnosis. So postpartum depression is a very anxious depression. You don't really tend to see the neurovegetative symptoms in the same way. Like, it's rare that I see someone who's like oversleeping, can't get out of bed. Really what we see is like someone who's just like filled with worry, filled with circular thoughts. They can't sleep when the baby's sleeping. Intrusive thoughts are incredibly common. It's thought that 100% of women in the postpartum will have intrusive thoughts of harm coming to their baby, and about 50% will have intrusive thoughts of them harming their baby. This is probably due to the brain changes that happen during pregnancy that kind of make the mom better at scanning for threats, right? When that probably increases the risk for intrusive thoughts. They feel really overwhelmed. A lot of times they'll feel like this was a mistake. There's a lot of mood lability that can cause a lot of issues in the relationship. So a lot of women I see really resonate with this term, postpartum rage. I think it's a little bit of a TikTok term, but it also does seem to be something that people really feel. They just feel so dysregulated. There's anxiety, often focused on the baby's or mother's health. So a lot of times it's like my baby's looking at me weird. Do they have autism, right? Or like people will be really worried about how they're healing. Like, are my stitches healing okay? What if my stitches are not healing? What if I'm never going to feel like myself again? There's a lack of interest or attachment to the baby, which I want to flag. We're going to come back to that because that might be part of why there's some deleterious infant outcomes from postpartum depression. And then depression symptoms are associated with the suicidal ideation, and 20% of women with postpartum depression have suicidal ideation. Symptoms must occur within 4 weeks of delivery or during pregnancy per the DSM, but clinically it's generally considered to be postpartum depression if it's happening within the first year postpartum. What is kind of interesting is that 33% of postpartum depression begins during pregnancy, so it's kind of a continuation of a depressive episode. What you'll see often is if you kind of drill down into the timeline with the patient, a lot of people start to have symptoms in the 3rd trimester. So they'll start to feel a little off, they'll start to feel a little down, they'll start to feel more anxious. And obviously there's a situational component to that too, right, with like an upcoming delivery and the upcoming changes. But also we think that there's probably a hormonal shift that starts. And for some people, depression starts in the 3rd trimester. The main rating scale we use is the EPDS, the Edinburgh Postnatal Depression Scale. If you've had a baby in the last 5 or 10 years, I'm sure you did this at your pediatrician's office, your OB-GYN's office, your primary care doctor's office. This has become a lot more common, which is great, right? A lot of people are screening. The problem now is really access, right? So if you screen positive, not everywhere has places to send these people. The reason we use the EPDS is because symptoms of pregnancy and postpartum overlap with depression symptoms, of course, right? You're fatigued, you have appetite changes, you have weight changes, you have sleep disturbances. And so those aren't very good screening questions. So like the PHQ-9, which I'm sure you're all familiar with, we try to take that out. So the EPDS really just focuses on the emotional symptoms of pregnancy or postpartum. I mean, the emotional symptoms of depression in pregnancy or postpartum. Here are the MDD criteria. We don't need to go over it. You basically diagnose them with depression with peripartum onset. So there's just the qualifier. Differential diagnosis, baby blues. Up to 75% of women will have baby blues. It's mild irritability, low mood, and tearfulness. But what's very important here is that it is never associated with functional impairment. So if someone is having functional impairment, suicidal thoughts, severe obsessional thinking in the first week or two, do not wait, treat them, right? This isn't, I know sometimes people will have the sense of like, well, let's see if they feel better in a week or two, but if there's functional impairment, it's postpartum depression and treat appropriately. Obsessive compulsive disorder, what we see a lot of times is that obsessive compulsive disorder really does seem to get worse in the postpartum, but what happens is that when people have intrusive thoughts related to the infant, they're much more distressing, right? So whereas you might have had other intrusive thoughts before, when you start having intrusive thoughts related to the infant, it seems like the OCD really ramps up, and probably the brain changes that happen in pregnancy make OCD worse. There's anxiety, of course, trauma-related disorders, especially postpartum PTSD. The rates can be as high as 15% with traumatic birth or pregnancy complications for postpartum PTSD. So always want to screen. I always ask my patients how was their delivery. Bipolar disorder. So an interesting statistic is that of those who have a depressive episode as their first episode of bipolar disorder, so meaning they didn't have a manic episode first, they had a depressive episode first, about 12% had postpartum depression as their first episode. So you just need to be aware of this, that for some women, the postpartum is when they're going to have their first kind of signs of mental illness. Other things you could consider, if you're just kind of in a clinic where you just screen for these things, you could use the EPDS, which we talked about, and you'd want to consider pairing it with the mood disorders questionnaire to kind of check for bipolar spectrum illnesses. Postpartum psychosis is very rare, but want you to be aware of a few things. Postpartum psychosis does not look like your typical psychosis in that it has cognitive symptoms, mood symptoms, and psychotic symptoms. The cognitive symptoms are interesting. So there can be perplexity. There's a loss of touch with reality. Sort of the classic example of postpartum psychosis that I've seen is someone who has a really long labor. They don't sleep at all during their labor. Maybe it's days, right? And then they don't really sleep again. And then over the course of the first few days in the postpartum, they really start to lose touch with reality. They can start to kind of question reality, like, where is my baby? Is my baby okay? But they're holding their baby. So really this lack of orientation that can happen. What's really important to know and what I want you all to know is that postpartum psychosis waxes and wanes, meaning there can be moments of lucidity interplayed with these moments of complete loss of touch with reality. And why this is important is if someone presents to the ER in like the first few months postpartum and the family members are saying they were psychotic, but they don't look psychotic, they should probably still be hospitalized because it could be a moment of lucidity. What we think is that part of the reason why the risk of infanticide is high with postpartum psychosis is because people will see them in a period of lucidity, they'll kind of leave them alone with the infant, and then sometimes that's when that happens, okay? Outcomes. So why do we care about postpartum depression? The main thing is that if we don't treat it appropriately, it can have a very chronic course. So these are sort of sobering statistics, right? 30 to 50% of women will continue to have major depression into the first year of their child's life. That's really tough. It's very hard to have a newborn. I have a 15-month-old, right? And to be depressed for the first year, I can't imagine trying to manage all of that and manage an infant, right? So we really want to treat, and we want to treat appropriately. There was another study that looked at people who sort of had their first episode of depression in the postpartum, found that about a third had sustained remission, which is fine, right? But 20% reported being depressed 50% of the time, out 13 years. So really, this can be kind of the beginning of mental illness for people. And just to remember that if someone has had postpartum depression, they're at a very high risk of having postpartum depression again. So why this is important is that a chronic course of postpartum depression versus intermittent episodic transient has a more deleterious effect on infant outcomes, okay? Postpartum depression over and over again has been associated with impairment of cognitive function, behavioral disturbance, poor physical health, insecure attachment, and depression in the offspring. So of the psychiatric disorders, it's my personal opinion, right, that postpartum depression is so important to treat because it's affecting that child's development, right? Part of the way we think that this effect is sort of passed on is that we know that depressed mothers interact with their infant in a different way than non-depressed mothers. And if you think about it, it kind of makes sense, right? When someone's depressed, they're more focused on their internal experience, right? Especially postpartum depression. So they're having anxiety, they're trying to cope with it. They might be having suicidal thoughts. It's very hard to engage with an infant when you're feeling like that. And so what we know is that in depressed mothers, mother-infant interactions are less affectively positive and less mutually responsive. So what that means, right, is when a baby coos, when a baby goes coo, right, you move in, you approach, right? If they smile, even if it's like a whisper of a smile, you do a big smile. And a lot of this is like very hardwired into our brain. And what it seems like is probably mothers with postpartum depression aren't able to engage in the same way. There are also other behaviors that are different, is they're less likely to breastfeed. There's interesting data that shows that women who have postpartum depression find breastfeeding more painful and actually get less of an oxytocin bump when they do breastfeed. So it's less rewarding for them than non-depressed mothers. They're less likely to attend well child visits. They're less likely to complete infant immunizations or use safety devices or place the infant on its back to sleep. So also important to screen in this population, sometimes you want to ask about co-sleeping, and that comes up especially with the new medication that we'll talk about that's quite sedating. Brief foray again, but something that I think is interesting, is that postpartum depression in the birthing parent also really increases the risk for paternal postpartum depression, so postpartum depression in the partner. Estimates with men is that the incidence of paternal postpartum depression in men when a birthing parent has postpartum depression is 25 to 50%, which is really high, right? The reason that we care is that having two depressed caregivers in the house is much worse for the infant, and having one euthymic caregiver is really helpful. So if you're treating someone with postpartum depression, you also want to screen and check in on how their partner is doing, because it'd be great, it's really helpful for the infant to have one euthymic caregiver. That could be a family member or a friend as well. Etiology. So hormonal change, right? So we think that there is a hormonal change that triggers postpartum depression, right? We've talked about how it seems like it's the change in level of hormones rather than the absolute level of hormones that triggers depressive episodes for some people. The hormonal change in pregnancy is wild, right? Estradiol increases by 50 times by the third trimester compared to typical menstrual cycle levels. Progesterone increases by 10 times. This is like another puberty. This is a big deal. Those hormones drop off fairly rapidly in the postpartum. And what's interesting, and I think is a really helpful way to conceptualize this, is that most women are sensitive to this change. That's why everybody gets the baby blues, right? Everybody feels this a little bit, but only some women go on to develop postpartum depression. So it seems like there's an individual susceptibility that probably increases the risk for postpartum depression. There was this one classic study by Block, and what happened is women were given pregnancy-mimicking hormones of estrogen and progesterone. So they gave them kind of these very high levels that were then withdrawn. And what happened is those who had a history of postpartum depression got depressed again. Those who didn't have a history of postpartum depression did not. So it seems like there's something in the brains of some women who get postpartum depression that's just different. Their body responds to these hormonal changes differently. We see this illustrated, so we see that progesterone and estrogen go up, and then they drop off. We also think that there could be HPA axis dysregulation, right? We know that adverse childhood events, we know chronic and acute stressors increase the risk for depression. They increase the risk for a lot of mental health disorders. They also increase the risk for postpartum depression. Stressors specifically in the postpartum also increase the risk for postpartum depression. We know that having adverse childhood events really has long-term effects on HPA axis regulation. Pregnancy is typically associated with blunting of stress-induced activation of the HPA axis, and conversely, in postpartum depression, it seems like they're really unable to suppress their HPA axis. So it's kind of like this high cortisol state. The one we'll focus on a little bit more today, these are obviously all interrelated, is the GABA glutamate dysregulation. So with progesterone, progesterone goes up during pregnancy, drops off rapidly in the postpartum. There's a metabolite called allopregnanolone that also goes up and drops off in the postpartum. Allopregnanolone is a positive allosteric modulator at GABA, meaning it increases GABA tone. When you increase GABA tone, it's calming. So think like benzodiazepines, think alcohol, right? GABA calming. So it goes up, up, up during pregnancy and then drops off. That drop off, so that withdrawal from the calming neurosteroid, might trigger depression in some people, and maybe that's why it's an anxious depression. There's also some preclinical data that shows that as allopregnanolone goes up in pregnancy, your GABA A receptors accommodate that. So that's why you are tired during pregnancy, but you're not like super, super sedated, right? That's because your GABA A receptors upregulate to handle that higher dose of allopregnanolone. What happens in the postpartum is as that drops off, maybe the GABA A receptors don't downregulate in the way they need to, and so there's sort of this like lack of GABAergic tone. What we know, and what we'll talk about more, is that positive allosteric modulators of the GABA A receptor, like brexanolone and zuranolone, which you may have heard of, are a treatment for postpartum depression, and they help restore this balance that gets off in the postpartum. So same sort of graph, progesterone and allopregnanolone go up, they drop off. All right, let's move on to treatment. So of course, we will always start with non-pharmacologic treatments for postpartum depression, but typically we will recommend these only for mild postpartum depression, okay? So for mild postpartum depression or moderate to severe in combination with medication, you would use cognitive behavioral therapy, interpersonal therapy. Those are the ones that have the most evidence. You would use exercise. We really recommend counseling people to get more sleep. So in the postpartum, right, infants are awake every few hours overnight. If someone's breastfeeding, they're really getting very, very limited sleep. We know that sleep disturbance increases the risk for postpartum depression, so we'll often counsel them, kind of meet with their partner too, sometimes to be like, how can we get you more sleep? What can we do? So some people will take shifts. Sometimes we'll recommend combination feeding, so introducing formula so someone can give a bottle overnight, but really workshopping this and kind of helping them figure out what works for them, and that can be a really, really helpful thing. In the postpartum, maybe more than other psychiatric disorders, you really want to consider a group setting. That's because you can learn through modeling. So when you're learning how to become a mom, it can be really helpful to be around other moms. In a group setting, I think there's a lot of normalization that can happen. People who have postpartum depression are often racked with guilt. They're like, why do I feel this way? I shouldn't feel this way. I'm a bad mom. And it can be so helpful to be in a group setting. And there's some evidence that peer support can be really helpful here, and that a group setting can just maybe help people more. in the perinatal intensive outpatient program at UCLA. So it's our 3-day-a-week program where we see pregnant and postpartum women. They bring their babies. We have a group room where they all hang out together, and sometimes just the group experience is really their favorite part because they sort of feel heard and understood, and they can be open about what they're going through in a way that they might not otherwise be able to. We'll first start with traditional antidepressants, so like the monoamines, or the ones that work on monoamines, and then we'll go into neurosteroids. So for traditional antidepressants, SSRIs are first line for moderate postpartum depression that hasn't responded to therapy or severe postpartum depression. There was a Cochrane review that showed that they were effective and safe, and had good safety and tolerability profile. If someone has never been on antidepressants before in their life, you would typically use Zoloft unless there was some contraindication. The reason you would do that is because Zoloft has low placental transfer into breast milk, and it's considered undetectable in the infant. So it's very breastfeeding compatible. That being said, pretty much all of the antidepressants across the board are breastfeeding compatible. The only medications that we really use in psychiatry where there's just like a little bit of concern are lamotrigine and lithium. Those just have higher levels in breast milk than are typically preferred, but we'll still use them as well. But across the board, you can use most antidepressants with breastfeeding. So for those who have prior treatment experience, just use the antidepressant that's worked before, right? If someone's tried 5 different antidepressants and venlafaxine is the one that works best for them, and they're not on it and they're having a postpartum depressive episode, just restart the venlafaxine. Please don't put them on sertraline. This is just more about breastfeeding. The cutoff that's typically used for breastfeeding compatibility is less than 10% of the relative infant dose. Most antidepressants are below that. There was a really nice review that looked at national and international society guidelines, and it basically recommended encouraging breastfeeding regardless of the antidepressant used, okay? The reason we treat with antidepressants is that we have good data that this helps to mitigate some of the negative infant outcomes and some of the negative familial outcomes. So SSRI treatment for postpartum depression resulted in improved maternal depression symptoms up to 5 years postpartum, improved maternal relationship satisfaction up to 5 years postpartum, and decreased risk of child externalizing problems and ADHD up to 5 years. So this is really good. This is why we want to treat postpartum depression and treat it fairly aggressively. Let's move on to neurosteroids. So zuranolone and brexanolone are synthetic preparations of allopregnanolone, right? So we talked about how allopregnanolone is the progesterone metabolite that goes up during pregnancy, drops off in the postpartum. It looks like if you give back a synthetic preparation of allopregnanolone, that might help to reset this GABA glutamate dysregulation that happens that may trigger postpartum depression. Like allopregnanolone, zuranolone and brexanolone are positive allosteric modulators of the GABA-A receptor, right? So they increase GABAergic tone. They're generally calming, sometimes a little too calming because they can be fairly sedating. We'll talk about it. But they generally have a calming anxiolytic effect. Zuranolone is orally bioavailable, is dosed once a day for 2 weeks. Brexanolone, which is no longer commercially available, was given as a 60-hour IV infusion. So we'll mostly focus on zuranolone today because this is the treatment option that's available to you. So there were 2 clinical trials that looked at doses of 30 milligrams or 40 milligrams once daily for zuranolone. What's interesting is that it's once a day for 14 days. So we don't often see this in psychiatry, right? But that's it. You just take it once a day for 14 days and you're done. So patients really like this. They like the idea that they can kind of take it and maybe feel better quite quickly. It has demonstrated efficacy as add-on or monotherapy. Clinically significant improvements were also seen in anxiety and insomnia. We know those are very comorbid in the postpartum. And 50 milligrams once daily versus placebo had meaningful improvements in depression scores at day 3 versus placebo that were sustained until day 45. Why that's interesting is the active treatment was for 14 days, but the improvement was up to day 45. So it seems like it may be sort of resetting this GABA glutamate dysregulation. There's also some thought that maybe this helps upregulate the GABA receptors to help them sort of reach the allopregnanolone that is there. The inclusion criteria you can read. We won't go over it today. I think the only thing that's interesting is that in the clinical trial, 15% of the people were on concomitant antidepressants. So here we see the data illustrated. You can see that there's response at 15 days and continues to 45 days. When we're looking at remission, we see that there's statistically significant remission at day 45 compared to placebo. Let's talk about side effects with zuranolone. So it is generally well tolerated. The side effects are typically somnolence, fatigue, dizziness. So it's a CNS depressant, which again makes sense. It works on GABA, right? But it is such a CNS depressant that it's recommended that you don't drive for 12 hours after taking it because they did studies and showed that these people were driving impaired. So typically what I'll recommend is people take it around like 6 or 7 p.m. That way they can drive by the time they wake up in the morning. Some people recommend they take it a little later. There was no increase in suicidal ideation in clinical trials. There were no withdrawal side effects in clinical trials. You have to take it with fat-containing food, and it's a pretty big meal. So 40 to 100 calories consisting of 20 to 50% fat, so a lot of fat. So I'll tell people, like, add extra oil, eat a few scoops of peanut butter, eat some avocado, but it's a big meal. The way it's dosed is a little interesting. So it comes in 20, 25, and 30 milligram capsules. So you have to prescribe 2 25 milligram capsules, which is interesting, but the recommended dose is 50. If someone is too sedated, you reduce the dose to 40 milligrams, so then you would have to re-prescribe 20 milligrams. It's only available right now through specialty pharmacies. So if you prescribe this to patients, you do need to tell them, like, answer your phone for unknown numbers for the next few days because there's a lot of coordination that has to happen. It's classified as a Schedule IV controlled substance. The abuse potential is comparable to alprazolam. This does not concern me because it's not available. So even if someone loved zuranolone, they can't get more zuranolone. So I would still use it in people with a history of substance use, but obviously with shared decision making. So here's how I counsel patients when I'm prescribing zuranolone. I'll be like, there's a medication that's indicated for postpartum depression. It's once a day. You take it in the evening with a big meal. The main thing is that it can be pretty sedating. Do you have a partner or someone else in the home who can help you take care of your infant for the first few nights while we're seeing how sedated it makes you, right? Because part of what you have to remember too is there's an infant in the home, and typically the mother is caring for the infant overnight. Zuranolone might make them less responsive to the infant's cues, meaning they might not wake up in the same way as they otherwise would, and if they can't drive, they might be clumsy. So a lot of times I'll just say, can we just have like your partner do it for the first few nights? Usually that's not a problem. If that's not available, it's not a reason that I wouldn't prescribe it necessarily, but you just would want to do shared decision making. If they're on any other sedating medications, I would recommend they probably abstain. If they're like a daily benzodiazepine user, maybe we would lower it, but that definitely will increase the risk of sedation. I recommend not drinking alcohol while you're taking it, and tell them to take it with a meal and not to drive for 12 hours afterward. Here are the side effects: somnolence, dizziness, diarrhea, fatigue. So the interesting thing is that with breastfeeding, it does seem to have very low levels in breast milk, which is great. They looked at the dose of 30 milligrams daily and found that the relative infant dose was less than 1%. They extrapolated that for the 50 milligram dose and found that the concentrations were also expected to be low. We don't have any data on infant outcomes yet, so I would say like cautiously proceed with breastfeeding while doing sort of informed care. But in the clinical trials, they had people stop breastfeeding for 2 weeks and for 1 week after. There are no direct head-to-head comparisons with SSRIs, but there was a matching adjusted indirect comparison. And what they essentially found is that when patients took zuranolone, they had a faster response than an SSRI. That kind of makes sense. That doesn't make me think that SSRIs aren't effective. It's just that when you're taking zuranolone, you're taking it at an effective dose on day 1, whereas when you're taking SSRIs, you're having to slowly titrate up to an effective dose. Factors to consider: cost. It is quite expensive. Most private insurances are covering it. You have to do a prior authorization, but if you give someone a diagnosis of postpartum depression, it's typically covered. But most commercial insurances are. But you want to think about prior response to treatment and especially comorbid conditions. Brexanolone, since we're running short on time, we're not going to talk about it. It's in here. Essentially, the problem was that it was a 60-hour IV infusion that had to be given in a monitored setting because of sedation and hypoxia. And so because of that, it had very limited accessibility. So here's Sage announcing that they took it away. Let's talk about the treatment recommendation. So this is my algorithm for thinking about how to treat postpartum depression. So for mild postpartum depression, we would use therapy. For moderate postpartum depression that's failed psychotherapy or severe postpartum depression, what you're really trying to assess is, do they have comorbid conditions that also need treatment? So what I'll see sometimes is someone has had low-level OCD that maybe even was functionally impairing at times, but they chose not to seek treatment, and then it got much worse in the postpartum. They also have postpartum depression. They have OCD and postpartum depression. That would be someone that I might use an SSRI for still, right? They've needed treatment for their OCD for a while, and what we know is that in the postpartum, people have a lot less time to do their coping skills, and they're going through this big hormonal shift. So on that person, I might start an SSRI. If someone has pure postpartum depression, it's their first touch with kind of mental health, they don't have any comorbid conditions, I would definitely use zuranolone at this point. It's effective for postpartum depression, and if someone doesn't need other treatment, you would do that. If someone is on antidepressants and they're having postpartum depression, you can either increase their antidepressant or you could have a discussion with them about adding zuranolone. So there have been patients that I've seen that have kind of like been rocking and rolling on fluoxetine 20 their whole life, right? They're like 10 years. They come to me in the postpartum with bad postpartum depression. That is a discussion. Do we either want to go up or do we want to give you zuranolone and see if we can kind of get you back to your baseline? Like you're having kind of a relapse in the postpartum because of stressors, because of hormonal change, maybe because of this GABA glutamate dysregulation. In those patients, sometimes we are giving zuranolone too, instead of increasing. Oh, I went backwards. Sorry. Okay, investigational treatments for postpartum depression. I have to whiz through these because I'm short on time. TMS, thank you, Dr. Luchter, for such a great lecture on TMS. But our TMS has been investigated, though more research is needed. But overall, it seems to be effective for treating postpartum depression. I typically use this in people who have comorbidities. So like I just treated someone who had severe chronic pain and postpartum depression. TMS is a great option for that patient, okay? Or if someone is just doesn't want to change their medications, we're running into medication side effects, you can definitely recommend TMS. And I've sent lots of people to Dr. Luchter. Ketamine is a really interesting investigational treatment. So it's typically been studied when they're looking at when it was given for anesthesia for a C-section, right? So ketamine can be used for C-sections. And then what they did is they looked at outcomes and looked at the depressive symptoms after that. And people who were given ketamine for anesthesia for their C-section had lower rates of postpartum depression. There was also a study that looked at when women had mild depressive in the postpartum, not enough to diagnose them with postpartum depression. They were given a ketamine infusion after childbirth, and that also seemed to decrease depressive symptoms. One more minute. Psychedelics are really interesting. So there is a compound that is in phase 2 clinical trials that is a psilocybin derivative for postpartum depression. This is interesting because if we think of postpartum depression as kind of this disconnection from the self, right? They're disconnected from their self, they're disconnected from their infant, they're disconnected from their partner and their community. Maybe psychedelics have a role. We also know that psychedelics have antidepressant effects. And so there's one compound, RE104, I think, that's being investigated. And so it'll be interesting to see like what that data shows and if that's helpful for postpartum depression. Do I need to skip my case example? Let me go through the case example really quickly. Okay. So this is a patient that I saw at the perinatal IOP. It just kind of gives you a sense of like the complicated things that come up. So this is a 35-year-old female, history of really, really extensive trauma, like torture, abuse from her sibling and father. She had brief therapy in college, but otherwise was treatment naive, which was amazing, like a very, very resilient woman. She had a supportive partner. She worked as a physical therapist. She had a miscarriage in 2023, was very depressed afterward, got pregnant, felt better during the pregnancy. She had a traumatic birth. The epidural wasn't working. She had to have spinal anesthesia, and she had trouble breathing and thought she was going to die. She felt low and overwhelmed since the baby's birth. She hadn't been able to use her typical coping skills because she did so many behaviors. She meditated, she did breath work, she did yoga, she exercised. You can't do that in the early postpartum, right? And I think that the birth really re-triggered her PTSD symptoms. She was having vivid memories of childhood abuse, passive SI, insomnia, feeling out of touch with herself, her partner, depressed mood, anhedonia, lack of motivation. She was started on Zoloft by an outside practitioner and came to me. In the perinatal IOP, she was receiving individual therapy, DBT, CBT, group support, attachment-based parenting intervention. She loved behavioral interventions because that's how she had always coped with her mood. She had no improvement on the 50 milligrams daily. We increased it to 75 and concurrently talked about zuranolone. Because this was an interesting case where she had PTSD symptoms, but she had also been doing pretty well most of her life off of medications. So we ended up giving her zuranolone while she was on the Zoloft. She reported that on the zuranolone, her intrusive thoughts resolved. She was spiraling less. She felt more like herself, and she felt more resilient. She had some residual anxiety after we finished the zuranolone, so we increased her Zoloft to 100. On admission, her EPDS was 25, which was severe depression, and when she discharged from the program, it was 16, which is moderate depression. For her, this was a huge clinical improvement. On the last day, she was like bright, ebullient, just so grateful. But it's interesting that she still had moderate depression on discharge. But just to give you a sense, it's complicated. I'm here to answer any questions. Thanks. Thanks.
Thank you, Dr. Vanderford. Very educational talk, lots of questions.
Great.
Since the audience have access to a reproductive psychiatrist, the questions are not just for postpartum depression, as you might expect.
Yes.
But for PPD, a lot of epidemiological questions.
Okay.
For minorities or immigrants, if you could take out the factor of social support, is there still a higher risk for postpartum depression?
We don't really know. I think that a lot of the epidemiological studies in postpartum depression and depression in pregnancy are complicated by that. We don't really know.
Okay, thank you.
Yeah.
Any higher risk? You listed risk factors there, but
Yeah.
PCOS, does that put people at a higher risk for PPD?
I would expect so, but I also haven't seen studies specifically linking it. I think I would like more information about PCOS and mood effects and sort of how we can tailor treatment to people who have PCOS. I would expect so, especially if someone is having anxiety and depression that's connected to their PCOS.
And how about same-sex couples, lesbian mothers or gay fathers? Is there a higher rate of postpartum depression?
In the partner? Mm-hmm. Definitely.
Or either of them?
We would expect so, but all of the studies that are looking at rates of postpartum depression in the partner are done in heteronormative cohabitating couples. So we definitely need more research on same-sex couples. There was a review recently that talked about the brain changes we see in men's brain when their partner is pregnant. And it did show that there were changes that sort of led them to be more nurturing, more focused on the infant. And we don't really know yet, is that because of interaction with the infant? Is that because their partner's pregnancy induces hormonal changes in them? Or is it something completely different?
Okay, thank you.
Yeah.
Teenage pregnancies and children either in the foster care system or otherwise have pre-existing psychiatric conditions or probably history of trauma and unintended or intended teenage pregnancies.
Yeah.
How do you go about psychotropic prescribing during pregnancy and postpartum? Any changes from the standard recommendations?
It depends on what's going on. So depression in pregnancy has negative outcomes for the pregnancy itself, like it increased risk of low birth weight, increased risk of child, like negative infant outcomes, like child development issues. And so if someone was coming to me depressed and pregnant, sort of no matter their age, I would treat them because we believe that not treating depression in pregnancy is generally considered unethical. That's why we can't do placebo-controlled trials in pregnancy, because if someone is depressed in pregnancy, we know that that's affecting the pregnancy itself, the fetus's developing brain and the mom.
So are people predisposed to hormonal depression? So if somebody has an onset of a depressive episode around the time of menarche, around age 12, 13, are they at a higher risk then to have postpartum when the next big change is going to happen in hormones?
Probably. Yeah. It seems like people who are sensitive to hormonal changes remain sensitive to hormonal changes. So if someone has depression starting around menarche, it's possible they might also have more severe PMS or PMDD symptoms. Whether or not they actually qualify for that diagnosis, they're probably also at risk for depression in pregnancy and postpartum depression and perimenopausal depression. It unfortunately seems to track. And most people will know, I'll ask people, do you think you're sensitive to hormones? And most of the patients that I treat would emphatically say yes. They would be like, yes, I am. I can't take hormonal contraception, right?
Family history of postpartum depression, does that increase?
Definitely,
Okay.
definitely, yeah.
Okay. Would you, the more the risk factors stack up, would you prophylactically treat?
It depends. Not generally. I think that if someone is not having symptoms, I don't tend to treat prophylactically. I think if someone was starting to have any symptoms in the postpartum with a family history, I might treat. But typically the patients I'm seeing, I see very psychiatrically complex patients. And so most of the time these patients are on medications already. The only thing I might do is if someone had a really, really debilitating postpartum depression and this is a second pregnancy and they're not on the regimen that kept them stable, maybe we would talk about, okay, now that you've delivered, should we just get you back on what kept you stable last time? You were really functionally impaired for a long time. I would definitely do that. But starting a medication in someone who was treatment naive in the postpartum just because of risk factors, probably not.
Okay, thank you.
Yeah.
Where would you draw the line of when is it too late to start zuranolone? Is there a timing as far as from onset of the baby's birth to, is it as effective 6 months after?
The data is up to 1 year.
Okay.
So there was a study, I believe, that they looked at postpartum depression in the first 6 months or in the second 6 months, and it seemed to be equally efficacious. That might also be because there was some data for MDD as well. It didn't get the FDA approval for that, but I would consider it even late in the postpartum, especially if the timing lines up with postpartum depression. Like if they'd been having symptoms for a few months or for 6 months, I would still consider it.
Thank you.
Yeah.
If for some reason somebody's uninsured or insurance doesn't cover, would you go to other PAMs like benzos or even a glass of wine?
Love that question. No, because zuranolone works on extrasynaptic receptors as well. It binds in a different location, and it seems like it probably upregulates GABA receptors, so it does have a different mechanism of action. So no, I don't. And there's some data even that like alcohol specifically might worsen premenstrual dysphoric disorder, maybe because of its effect on GABA. So no, we don't recommend alcohol.
Thank you.
But I love that question.
Sorry, guys.
So fun. Yeah.
Just pivot a little bit to insomnia in pregnancy,
Yeah.
ADHD in pregnancy, any absolute do's and don'ts from what you would prescribe or not prescribe?
No. For insomnia in pregnancy, it really depends on what the cause is of the insomnia, right? So if it's severe anxiety, we might use an SSRI. If it's something else, a lot of times we would try doxylamine first, right? Unisum, that is considered pregnancy safe. If that doesn't work, typically I would prescribe a benzodiazepine at a low dose for intermittent use. But also, I think it's very important when treating insomnia in pregnancy to lower the expectations. I think that pregnancy, I think it's like 95% of women have sleep disturbances in pregnancy. It's just so common. It's almost like part of the experience. The old wives' tale is that, right, you have insomnia in pregnancy to teach you how to nap better, right? Because you need to learn how to nap when you have an infant. So part of it is lowering like the expectation, sort of what can we do behaviorally to help you cope with it, and then definitely medication. For ADHD, there's more and more data that really shows that not treating ADHD during pregnancy isn't benign either. It really affects like the woman's functioning. It affects like familial outcomes. I think I treat a lot of like older professional women who are waiting later in their life to have babies, and their stimulant is very important to their functioning, right? They can't just stop being a lawyer for 9 months, right? So we'll continue it on a case-by-case basis. We have more data that stimulants don't seem to increase, like this is on methylphenidate and amphetamine. They don't seem to increase the risk for major congenital malformations. They might affect pregnancy outcomes a little bit, so depending on when they're used in pregnancy, they might slightly increase the risk for preterm birth or preeclampsia, but the absolute risk is quite low. And we have some newer neurodevelopmental data that shows that they don't increase the risk for autism or ADHD. We don't really have any breastfeeding data, but typically if something's taken in pregnancy, you can take it in the postpartum. And so sometimes people will continue on their stimulant. A lot of times we'll try to get it on the lowest effective dose possible. If they haven't done any executive coaching, we would recommend they do that too.
So we understand the mantra, if somebody's on it, keep them on it. But if somebody's not on anything, then any SSRIs that you would recommend during pregnancy or would not recommend, considering the risk of congenital cardiac malformations or autism risk?
Yeah, so as a class, SSRIs are not considered to be major, they're not really considered to have any of the negative outcomes that we've talked about. But if I got to choose any SSRI, you would typically use sertraline, just because it's considered to have low placental transfer and it's very compatible with breastfeeding.
Thank you.
Yeah.
We can't have a talk without talking Lamictal.
Yeah.
Pregnancy and breastfeeding, both.
Yes, so Lamictal has a lot of safety data because there are big epilepsy registry studies. So we've collected a lot of data on Lamictal. It does not seem to increase the risk for major congenital malformations. It doesn't seem to affect pregnancy outcomes. And it's not considered to increase the risk for any neurodevelopmental outcomes. So it's fairly compatible with pregnancy. The main thing is that estrogen induces the metabolism of Lamictal. And so as you guys all know, right, estrogen increases in pregnancy, so Lamictal levels get lower and lower and lower. Since we are psychiatrists, that doesn't tend to matter as much. I still treat clinically, so if someone starts to have symptoms, you would increase the medication, and you know that their levels are getting lower in the 3rd trimester. Some people will check levels regularly during pregnancy. In breastfeeding, what happens is that the levels in Lamictal are just variable. Some studies show that they're well above the 10% cutoff that we use. So often I'll have people identify a pediatrician and talk to a pediatrician about this before they deliver. A lot of times my patients who are on Lamictal tend to not do well with sleep disturbance at baseline. So I'll sort of ask them, what are your plans for breastfeeding? They'll be like, yes, I definitely want to do it. And I'll be like, well, how do you do without much sleep? And they'll be like, terribly, right? And I think they don't always understand how much sleep deprivation is really required to exclusively breastfeed. So a lot of times I'll introduce the idea of combination feeding. So using formula and breast milk. That way, not only can a partner give a bottle overnight so you can get more protected sleep, but also it lowers kind of the effective exposure to the lamotrigine.
Thank you.
Yeah.
Last question. Any data that supports one atypical antipsychotic over others during pregnancy or breastfeeding?
Typically with atypical antipsychotics, we use older 2nd-generation antipsychotics. So that's like quetiapine, Geodon, olanzapine, and Abilify. Those are the ones that we would typically use during pregnancy. But that being said, if someone is on an antipsychotic for a psychotic disorder and they have found one that works for them, I would not recommend changing it. You really want to keep someone on that stable. We know that people with psychotic disorders have a really high risk of relapse during pregnancy and in postpartum, so just keep them on what's stable. There's a little bit of data with Latuda, but not quite as much as we want, but that one is being more commonly used. The main thing with antipsychotics is that in so much as they're associated with weight gain and metabolic syndrome. It seems like maybe olanzapine and Seroquel increase the risk for gestational diabetes. So you just need to be really aware of that because gestational diabetes has bad outcomes, right? So we'd like to avoid that if possible.
We are unfortunately out of time.
Okay.
Thank you very much for this talk. If you could please be there for a few minutes for our audience.